So I'll talk about connective tissue disorders. They're mainly SLE, systemic sclerosis, and dermatomyositis that you need to know a lot about. You need to know the skin manifestations and the antibody profile, the autoantibody profile, and the basic investigations. So we'll start off with a question. Erythema nodosum is seen in all of the following except pregnancy, tuberculosis, chronic pancreatitis, and infectious mononucleosis. So the answer here is infectious mononucleosis. Okay, all the others are conditions where you can see EN, erythema nodosum. So what is erythema nodosum? It's a type of paniculitis. That means an inflammation of the subcutaneous fat. All right. It presents as tender red nodules. That's because it is inflammation in the fatty layer that is underneath the epidermis and the dermis. And so this occurs mainly on the shins, classically. Can also occur upper thighs and the forearms as well. You may have on the flexor and extensor aspects. Okay, so the tender red nodules, and they heal with hyperpigmentation and like a bruise-like appearance. And this is much more common in females than males. Occurs a lot in connective tissue disorders, and it's usually accompanied with fever, joint pains, and joint swellings, as well as pedal edema. So the causes of erythema nodosum, in more than 55% cases, the cause is unknown. Okay, it's idiopathic. Other common causes. So coming to infections, we have the streptococcal throat infection, TB, of course, chlamydia, which is an STI. Okay. Deep fungal infections like histoplasmosis, coccidioidomycosis can also have EN, and viral infections like HIV as well as herpes simplex. Protozoal infections, amoebiasis, giardiasis, less common practically. Okay. Pregnancy, EN can be seen. Inflammatory conditions like inflammatory bowel disease, so that's Crohn's disease and ulcerative colitis, as well as Behçet's disease. Drugs can also cause erythema nodosum. Commonly, we would say NSAIDs, sulfonamides, okay, amoxicillin, and OCPs can also cause EN. Malignancy as well, EN can occur in malignancy. One important thing to know is that erythema nodosum heals without scarring, all right? That is important because there are other conditions like vasculitis, for example, which occurs on the legs, and erythema induratum also, which can heal with scarring, okay, though they appear similar to erythema nodosum. Okay, investigations for EN, the CBC, ESR for underlying inflammatory disease, and CRP as well. Chest X-ray for TB and sarcoidosis, that's another cause. Throat swab for and ASLO titers. Okay, viral serology, Mantoux test, and a skin biopsy. Now, the skin biopsy has to be a little deep to involve the subcutaneous tissue. That's why they see a deep incisional or an excisional biopsy. Take out the whole lesion and check the histopathology. So on histopath, what you're seeing here is the subcutaneous fat. Those are the white, right? The globules of fat. And in between these fat globules are the septa, right? That's the connective tissue septa, which has collagenous bands. And here you will see septal paniculitis. Okay, that means the inflammation or the inflammatory cells are between the lobules of fat, okay, in the septa and around the septa. You will have edema in the septa as well, and the inflammatory cells are mixed type of inflammatory cells. So differential diagnosis is paniculitis that may occur in connective tissue disorders as well, like SLE and scleroderma, polyarthritis nodosa, and vasculitis. Now these are the conditions I was saying where you get skin lesions that mimic erythema nodosum, but they can heal with scarring. Erythema nodosum leprosum, that is type 2 lepra reaction. Okay, that also looks just like EN. Erythema induratum, which occurs on the inner aspects of the thighs, whereas erythema nodosum occurs on the outer aspects, okay, on the shins. And lipodermatosclerosis as well, which is induration and thickening of the skin as well as tightening on the calves and below, okay, towards the ankles. That's usually accompanied by venous insufficiency. Treatment of erythema nodosum, besides rest, leg elevation, NSAIDs are actually used to treat them. NSAIDs are also sometimes the cause of erythema nodosum. Anti-inflammatory colchicine, okay, in some cases dapsone as well can be used. Oral steroids can be quite useful once you rule out underlying infection, and in some cases iodine, also potassium iodide, is given as treatment, but not very often. So iodine is usually used to treat deep fungal infections. Okay, carpet tax sign is seen in syphilis, psoriasis, lupus vulgaris, or DLE. So the answer here is DLE. Carpet tax sign or tin tax sign or cat's tongue sign, okay, is seen in discoid lupus erythematosus. I'll explain what this is. In psoriasis, what sign would you see? There is the Auspitz sign. Okay, that is when you're removing the scales of a psoriatic plaque and you elicit pinpoint bleeding as the end point, right? That is called Auspitz sign. In lupus vulgaris, you would see apple jelly nodules when you do diascopy, right? That's when you take a glass slide and you press it on the lesion. What you'll see there, once the lesion is compressed, you'll be able to see apple jelly nodules, okay, erythematous nodules. So carpet tax sign, this is a photo of scalp DLE. Okay, these photos are very important. It helps you understand easily. Okay, and you may even get some photos as exam questions. So you can see these thick scales, adherent scales. Okay, there's inflammation at the borders of the lesion. You can see erythema. Okay, underlying the scales, and there is alopecia. There's a patch of alopecia which is scarred. The scarring means you cannot see the hair follicles anymore. Now, this is not easy to see with the naked eye. You would usually need to use a dermatoscope or a magnifying glass to look and see that the hair follicles have been completely obliterated. But the shiny appearance gives you an indication that there's scarring alopecia. So when you remove the adherent scale from the lesion, the undersurface of the scale will have horny plugs, which are the ones which fit into those keratotic, the hair follicles. That is called the carpet tax signs, like when you're removing a carpet from the floor, okay, and it's hooked on by a tax. So this is another photo of DLE. Classically, you may see these keratotic lesions in the ear canal, all right? And so they're like scaly plaques in the ear canal. So it's a very important location to look for a DLE. So DLE occurs as chronic scaly disc-like, so that's why it's called discoid. Plaques usually occurs on the scalp and the face, as well as the ears. So these are scaly plaques which will heal with hyperpigmentation as well as depigmentation, depending again on the patient's skin type. So in darker skin types, they can heal with a depigmentation, and then the area around the lesion will have a hyperpigmentation. Other changes like you can see in healed old lesions of DLE are telangiectasia. There will be scarring, and on the alopecia, as I said, is scarring alopecia. So there will be hair loss as well. 5 to 25% of patients with discoid lupus erythematosus will eventually develop systemic lupus erythematosus. So it's not very common in a DLE patient. This is another photo just to show you how DLE looks. This is on the nose and on the cheeks of the patient. So there is some atrophy. Okay, this is a healed lesion. So there is some remnant erythema. So probably telangiectasia if you look up close, as well as atrophy. You could see some depigmentation also. Okay. Investigations in DLE. So besides the CBC, creatinine, CRP, and ANA, you would basically investigate in DLE to confirm if they have coexisting underlying systemic symptoms indicative of SLE. That is why you would normally investigate a DLE patient. All right. So these circulating autoantibodies that are seen in SLE are found in about 50% of patients with DLE. But as long as you monitor renal function tests and just generally the CBC, make sure they don't have anemia, then you can treat them just for their skin symptoms. The treatment in discoid lupus is sun protection. Topical steroids are also quite effective in treating localized lesions, and once they heal, you can use calcineurin inhibitors, tacrolimus, and milder one is pimecrolimus. Okay, these are topical. Hydroxychloroquine, antimalarials are also used in DLE because they also are part of the sun protection part of the treatment, okay, and anti-inflammatory, of course. Okay. A female presents with history of color change in fingertips from pallor to cyanosis on exposure to the cold. This condition is associated with scleroderma, leukemia, bronchiectasis, or hepatosplenomegaly. So the answer here is scleroderma. So what they're describing here is Raynaud's phenomenon, right? Color change in the fingertips on exposure to cold without any ulceration or without any permanent deformities. Raynaud's phenomenon is one of the major criteria for diagnosis of scleroderma, systemic sclerosis. So what is systemic sclerosis? There are two subtypes, okay, that you need to know, and this depends on the distribution of the skin involvement. So in diffuse systemic sclerosis, there is widespread skin involvement, and that means it includes the proximal part of the limbs. That means the sclerosis of the skin goes above the elbows and above the knees as well. It's rapidly progressive, and some cases can have significant internal organ involvement. The organs involved are typically kidneys and the lungs as well. Okay. GI system also. Now, in limited systemic sclerosis, that is, the sclerosis is limited to the digits, okay, or the distal part of the limbs, that is not proximal to the elbow or the knees. And also the face is also involved in limited systemic sclerosis. It progresses slowly, and internal involvement is usually less, but pulmonary artery hypertension is more common in limited systemic sclerosis. Okay, so limited systemic sclerosis was also known as Crest syndrome. So that's abbreviation for calcinosis, cutis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. In diffuse systemic sclerosis, the female predominance, so the female to male ratio is 9:1, and the age of onset is usually in the early or late 20s. Okay? The key features in diffuse systemic sclerosis or in scleroderma in general is sclerodactyly, that is the spindle-shaped fingers, right? The tightening of the skin over the fingers. Abnormal nail capillary fold findings. So that is very important. The nail folds will usually have capillary dropouts. Okay, so dermoscopy or capillaroscopy of the nail fold is very important in diagnosis of systemic sclerosis. It's a very useful clue, okay, to diagnosis. Specific autoantibodies. In diffuse systemic sclerosis, the anti-SCL70, okay, or the topoisomerase, it's called, topoisomerase 1, and the anti-centromere antibody are important for diagnosis. And you have internal organ fibrosis and vascular damage. So this is something that you need to know, the EULAR classification, it's 2003, and a score of 9 or more confirms the diagnosis. So just read through the points. As I said before in the previous slide, the important ones were the sclerodactyly, the nail fold capillary findings, the sclerodactyly, nail fold capillary findings, autoantibodies, and internal organ involvement. So the important autoantibodies, I'll tell you in the next few slides. Okay? So here are some photos. So this is sclerodactyly in the first photo. The second one is microstomia, the bird-like, faces, because the mouth tends to shrink because of the sclerosis and tightening. So it's like a bird-like appearance. The nose also tends to become more pointed. The face skin tends to get tighter. And you can see telangiectasia. You may have mat-like telangiectasia on the cheeks. It just means like, like a mat. So checkered type of telangiectasia. And this third photo is the nail fold capillaroscopy. So you can see there are nail fold, you will be able to actually see the nail fold capillaries in a normal capillaroscopy, but here you will have vascular dropouts, okay, because systemic sclerosis affects the vascular system as well. Here are some other findings. So you may have puffy hands. Salt and pepper pigmentation is another cutaneous finding. You may have that on the chest or on the forehead as well. It's just a skin finding in this. Digital ulcers. So along with calcinosis cutis, which you can see in the last photo down there, there's calcinosis in the digits. Along with that, you will have fingertip stellate ulcers on the pulp of the fingers. That's very important in systemic sclerosis. So the important antibodies to know in systemic sclerosis. For diffuse systemic sclerosis, anti-SCL70 or topoisomerase 1. as well as RNA polymerase 3. Okay? In limited systemic sclerosis, it's the anti-centromere antibody, and there's a connective tissue overlap or a mixed connective tissue disease, which you will have a U1 RNP antibody positive. Okay? So the treatment of Raynaud's phenomenon is, besides, of course, protection from the cold, physical protection, and smoking cessation, the drugs used to treat Raynaud's phenomenon are nifedipine and diltiazem, as well as losartan and sildenafil. All of the following can cause lupus except hydralazine, clofebrate, D-penicillamine, and isoniazid. So this means drug-induced lupus. So among these, the drug that does not cause drug-induced lupus is clofebrate. Okay. So this is a list you just have to memorize. Common drugs causing drug-induced SLE: procainamide, hydralazine, isoniazid, minocycline, that's very important to know, methyl dopa, terbinafine, and NSAIDs. That's less common. So some characteristics of drug-induced SLE. SLE is predominantly seen in females, but drug-induced SLE has no strong female predominance. There is some certain genetic factors that predispose a patient to getting this, and it's usually seen in an older age group. It typically tends to reverse once the drug is stopped over time. Okay? And skin manifestations are not so common in drug-induced SLE. So the cutaneous features of SLE, 80% patients of SLE will have cutaneous features, all right? So there are specific cutaneous features and some non-specific which may occur in other diseases as well. So there's a huge list. I'll just go through them slowly with you, okay? So initially in SLE, they say that you may have skin rashes in about 25 patients as one of the presenting symptoms. And these typical rash of SLE is usually photosensitive, so aggravated by UV light, and they tend to occur on the sun-exposed areas, right? The V of the neck, the face, and the forearms. So SLE, to simplify it, we will classify them into acute, subacute, and chronic cutaneous features, all right? So acute cutaneous features are the most severe types. So the typical one is the manna rash or the butterfly rash. So that's a rash which is occurring on the cheeks, on the prominences of the cheeks, and it typically spares this nasolabial fold, right? That's because it tends to get hidden from the sun, from direct UV light. So that erythematous rash, which spares the nasolabial fold, and it occurs both over the nasal prominence as well as the cheeks. You may get maculopapular rashes which resemble a drug rash. Mucosal ulceration, so oral ulcers are common in acute SLE. They may occur anywhere on the nasal, the oral, or the genital mucosa. Bullous SLE is less common, but if it occurs, it can resemble toxic epidermal necrolysis, so that can be quite severe. Photosensitive rashes, as I said, and diffuse hair loss is a very common feature in SLE. You may have brittle hair, so uncombable hair. You may have, yes, a thinning of hair is very common, especially in front in women, and it's a non-scarring alopecia. So that means it's just a gradual thinning of the hair, but there's no permanent scarring, all right? So here you see the butterfly rash. This is a bullous SLE photo. Mucosal ulcerations, which can be quite severe. So those are hemorrhagic crusts on the lips over there in that patient. That's quite common in acute cases of SLE. And here you have a diffuse hair loss. But here they're showing some scabs. So it's not very clear about which type of hair loss, but they're showing a diffuse hair loss in SLE. Okay, subcutaneous cutaneous SLE. So remember that these rashes resemble psoriasis. So they're annular or round, okay, erythematous scaly regions, and they resemble psoriasis. They're on the photo-exposed areas. They do not heal with scarring. So these are the various types of rashes, subacute SLE. Now, chronic SLE, think of DLE, okay? That's what chronic cutaneous LE is basically. Usually it's localized, okay? Some other variants of cutaneous lupus, there is a hypertrophic or warty lesions you may have, okay? Tumid lupus, which is basically a swelling again in the subcutaneous fat. Lupus paniculitis, and chilblains also. So these are the non-specific features like livedo reticularis, vasculopathies and vasculitis are very common in lupus SLE. So again, this is the diagnostic criteria looking at both clinical features and immunological features. You don't have to memorize this, but know the important features. So I've already described all most of the cutaneous features. Among these, so you just have 4 cutaneous features. That is one of the acute or subacute cutaneous lupus rashes, or the chronic cutaneous lupus rash, oral ulceration, and non-scarring alopecia. Those are the 4 cutaneous features. Okay, the rest are all the non-cutaneous and the immunological features as well. Okay, so this is the autoantibody profile. Of course, you know there are many autoantibodies. The important ones to know are usually these. So ANA is very sensitive for diagnosing SLE, all right, though it's not very specific. So that means with just an ANA and without any clinical features, you cannot really diagnose SLE. Anti-dsDNA is highly specific for SLE. Anti-SM is the most specific antibody for SLE. And anti-SSA or Rho and La are usually seen in neonatal lupus and Sjogren's syndrome. Okay. When you come lower down, you have the ACLA and the lupus anticoagulant, which can also be positive in SLE. And at the bottom, there's anti-histone antibody, which is commonly asked question. It's seen in drug-induced lupus. Okay, Gottron's papules seen in dermatomyositis, all are true except seen on the knuckles, violaceous, bullous, or seen in 30% patients. So Gottron's papules, all the features are correct. Okay, it is not bullous. So these are erythematous or violaceous papules which are seen on the knuckles. Okay, and they're seen in about 30% of patients of dermatomyositis. So in dermatomyositis, you have a female is to male ratio of 2:1, and it's an older age group. So that's age above 50 usually when the disease starts. About 25% of the older patients usually may have an underlying malignancy. So the classical features is proximal muscle weakness, that is weakness in lifting the arms, right, or lifting or leg weakness. Elevated CPK, that is muscle enzymes, and a rash which is like a heliotropic rash. So that's a rash affecting the face, the chest, and the arms and hands. So I'll show you photos again for you to remember easily. Keywords here in dermatomyositis are heliotrope rash, shawl sign, okay, which is a rash covering the front and the back, upper back, and a scaly scalp. Gottron's papules, as we described already, ragged cuticles and mechanics hands. So basically you'll have rough keratotic hands, and ragged cuticles are the nail fold, okay? The cuticles will be ragged. Calcinosis cutis is quite common in juvenile dermatomyositis. That is, you will have calcified nodules over here which may ulcerate, okay, both on the palmar and the dorsum of the hand, and Raynaud's phenomenon is also seen. So here are some photos. The heliotrope rash is on the upper eyelid, okay, can be violaceous or erythematous. Gottron's papules are there, seen on the knuckles and the dorsum of the fingers, and the ragged cuticles are seen in the last photo. This is basically to show you what like mechanics hand looks like, and on the back in the second photo you can see some small ulcerations that could have been a calcinosis cutis which has ulcerated. So the main points for diagnosis are the muscle enzymes, CPK and LDH levels. A skin biopsy and a muscle biopsy would help pinpoint a diagnosis, but you have further tests for the muscle weakness, so the electromyogram and an MRI, of course.